Hello and welcome to the 2013 WNA Nurses Day at the Capitol webinar series. Our next speaker is Gina Dennick-Champion. Gina is WNA's Executive Director and works in close collaboration with the President and the Board of Directors of WNA. She also works with the membership in implementing WNA's strategic imperative. She holds a bachelor's and master's degree in nursing, as well as a Master of Science in Healthcare Administration. Her clinical specialization is gerontology. Gina represents WNA on a variety of state and private organization boards, committees, and advisory councils, and is a frequent consultant and presenter on current issues in healthcare and nursing practice. Please welcome Gina Dennick-Champion.
This is Gina Dennick-Champion, and I'm the Executive Director of the Wisconsin Nurses Association. And today I'm talking about, we have a nice opportunity to look at a legislative proposal that has to do with title protection and licensure for advanced practice registered nurses in Wisconsin. Why are we doing this? Why are we looking at this? First of all, we can talk about advanced practice nursing has really become a lot more grounded and recognized in Wisconsin. And as we are beginning to move forward in our healthcare reform and the increased demand for primary care and nurses working as hospitalists, when we look at our current state statutes, 441, our Nurse Practice Act, we're not seeing that much text about the advanced practice nurses in Wisconsin. And there is a group of us, it's called the APRN Coalition, which is made up of WNA, the Wisconsin Clinical Nurse Specialists Association, the Wisconsin Nurse Midwives, and the Wisconsin Association of Nurse Anesthetists. We've been working on how do we create more visibility and clarity around the advanced practice nurse. So we see that in terms of some background information for you, that the growth in our patient demand for primary and acute care services is not keeping pace with the supply of the traditional clinicians, as we know. So what we're seeing is more and more advanced practice nurses being hired and used in these once traditional slots as working as either the primary care advanced practice nurse or the primary care provider of care, as well as, again, like I said, in our acute care settings, as more of in that hospitalist role. And we also see that that the use of the advanced practice nurses seem to be showing up in larger populations in terms of our densely urban areas and our rural and frontier areas. And with that, we're seeing, they're seeing folks with not a lot of insurance, if they have insurance at all, and that their knowledge of the healthcare system is not very well known, nor are they good navigators of that. So what we're seeing is the once traditionally assigned physician, we are now seeing the advanced practice nurse. When I start with, again, we talked a little bit about why we're interested in changing statutes. First of all, we don't have a very good definition of who is an advanced practice nurse. Like I said, State Statute 441, our Nurse Practices Act, is relatively silent when it comes to describing who is the advanced practice nurse. We also have more information regarding the advanced practice nurse work roles, and that's sort of their skills and their competencies and their experiences and what they bring to the setting is being sought after by insurance companies, risk managers of hospitals and other systems, human resources as they begin to hire these folks, consumers, and legislators. And what we find is some of these different groups go to our state statutes to look for a description of who are advanced practice nurses. And because they can't find it, they often call WNA and asking us to further define and the the role and what they can do and not do. So given that, and given our APRN coalition, we decided that it's time to provide a legal description of who is the advanced practice nurse in Wisconsin and get it into our state law. As we began to look at what sort of language do we need, at the same time, there was a national consensus model emerging that was created by the nation's nurses, meaning our educators, the folks that educate advanced practice nurses, employers. So we had both physician groups as well as the nurse executives. We had the regulators, and the four roles that represent who the advanced practice nurse is. And out of this national consensus model, as it was adopted, we find four major themes. The first one had to do, in terms of agreement, was the issue of licensure, accreditation, the accreditation of the actual educational institution that is graduating the advanced practice nurses, certification, and that would be certification of that specific advanced practice nurse, where they take a nationally recognized examination for certification or board certification. And lastly, the educational preparation of the advanced practice nurse, regardless of the four roles. What they all agree to is there are some very basic elements that should be in every educational curricula, regardless of the specific role. So when we put those four themes together, licensure, accreditation, certification, and education, it's called the LACE model, LACE. And you can find more about this model on the National Council of State Boards of Nursing's website. You would just need to go to ncsbn.org. And some of you may be familiar with NCSBN, as that was the testing agency for all of us as registered nurses when we had to sit for the NCLEX exam to determine our ability to work as a registered nurse or not. So we're using the LACE model to help drive the statute changes that we would like to see in Wisconsin. The other piece that was happening at the same time was the issue of the protection of our four titles. We found that in Wisconsin, there were some organizations that were calling a nurse without the master's degree or even the extensive, even the graduate education as their employees and calling them nurse practitioner. So in terms of what WNA, we did ask that the agency cease from doing that, calling their employees nurse practitioners, which they did not want to do. So we filed a complaint with the Board of Nursing asking them to ask the organization to please cease. And what we found out is that the title, nurse practitioner, CNS, clinical nurse specialist, and CRNA, certified registered nurse anesthetist, are not protected titles in our state statute. And it was recommended that we pursue that. The only protected titles we have right now in our statutes is LPN and registered nurse. We find that it was important to make those changes. We do believe that more and more of our consumers do know who a nurse practitioner is, and they have the knowledge of who they are. And when they go and they meet get their health care from someone who's calling themselves nurse practitioner and they're not, we find that very deceptive practices. So by given this, we are working on, in our statutes, to work on protection of the title and protection of the name. As I described, we had our coalition, which has been working very hard over the last 2.5 years on creating a statute change that really begins to support and codify what it is advanced practice nurses do. And at this point in time, I want to share what is in our legislative proposal at this time. First of all, like we said in the LACE model, licensure, we are exploring having a separate licensure, and the name of that license would be Advanced Practice Registered Nurse, or APRN. In addition, we have the nurses that have authority to prescribe. They would be called the Advanced Practice Registered Nurse Prescriber, or APRNP. The reason for the separate licensure, number one, it is what's happening across the nation as they begin to create and also define who these advanced practice nurses are. So we're coming into conformity with the other states, and including those around us. The other piece is that we've talked about how advanced practice registered nursing is emerging, is being recognized, and it also has expectations of skills and competencies beyond that of the registered nurse. They have the additional education, they have the additional experiences, and they have a different scope of practice. So given all of these things, we are recommending that we have a separate license. It does mean, though, that you have to have the registered nurse license in order to get or be endorsed for an advanced practice registered nurse license. We are also not changing any of the procedures or the requirements for how an advanced practice nurse obtains the prescriptive authority certificate. So we're saying that APRN will be a title, and that will be the umbrella for the 4 other APRN roles. So in what we would see is the APRN Certified Nurse Midwife, or CNM, or the APRN Certified Registered Nurse Anesthetist, or CRNA, the APRN Clinical Nurse Specialist, or CNS, and the APRN Nurse Practitioner, or the NP. With that, we're feeling that that's sort of, however, that APRN will be signing their name in terms of documents or whatever in terms of signing their prescriptions that they, or any of their documentation. The other piece is that the advanced practice registered nurses who are not interested in prescriptive authority will use PRN. And we do know that there is a subset of nurses where they are working and employed as an advanced practice nurse. The majority of those particular folks are working in the hospitals, delivering some direct care, but in a very, degree of specialty, or they are working more in the world in the hospital or those institutions as system planners, system reviewers, data, crunching the data, bringing it back to the nursing units, or also being there as that clinical consultant. Another thing that we want to address has to do with some legislation that we were considering having introduced on its own, but the legislative drafter has been is recommending that we can put this right into the legislative draft. This has to do with the section in the statute of 441.11. If you were to look at that, you would see it's called nurse anesthetist, and what this particular section talks about or describes is the ratio of anesthesiologist who is working as the instructor to the student nurse anesthetist. And so the ratio of that individual to the 2 nursing students. And what's in the statute is got to be a 2-to-1 ratio. So no more than 2 students to 1 anesthesiologist as the clinical instructor. This was put in last session, which came as a complete surprise to WNA and also the Board of Nursing. It was a piece of legislation that focused on the licensure of anesthesiologist assistants, which had some implications for or impact on our CRNAs. And part of the negotiations that went into this particular bill resulted in the addition of this 441.11. The issue for WNA and nurse educators is now there has been put into statute a nurse instructor ratio to students that could be used for other purposes throughout the education statutes. Having a 1-to-2 ratio is not feasible. It will not work if it was to be done in any other setting. We think about a lot of the nurse instructor to student nurses in the clinical setting is usually a 1-to-8, sometimes a little less or sometimes a little more. 1-to-2 would, number one, be cost prohibitive for both that student who's paying their student fees. Not to mention, I don't know if we'd have the supply needed for nurse instructors to meet that. The other piece to this is that in 441, it's very clear that it is the Board of Nursing that is responsible for the educational standards of the school. They use measures of the NCLEX scores. Any major curricula change must be submitted to the Board of Nursing. We've had our Board of Nursing members also actually doing site visits on some of our schools of nursing. So needless to say, this language is not necessary. It's too restrictive, and it certainly doesn't maintain the contemporariness of our Practice Act. Another section that we'd like to see removed is section 441.15. This has to do with the certified nurse midwife. When we look at the other 3 roles, only the nurse midwife has the description about their role as an advanced practice registered nurse. They are also, in their statute, they are licensed, so they do have a 3rd license. When you look at their statutes, you find some barriers to their ability to practice to the fullest scope of their license. And some of the language is more restrictive than what even the other advanced practice nurses have in Wisconsin. So it is recommended that we're going to remove this section and that all the certified nurse midwife title and role will all be under that newly created APRN umbrella. Other pieces that are going to be, that we're looking at that we'd like to see is there is a section in the hospital statutes, and it's chapter 50 point, I want to say 36, or it could be 35, but it talks about hospitals being prohibited from discriminating against physicians, podiatrists, and I want to say, I'll think of the other group in a minute, but you can't discriminate against these folks just because they are a physician or a podiatrist. So in terms of allowing them to admit. What we would like to do is include in the language the addition of the advanced practice registered nurse prescriber. we are seeing more and more demand for the APRN prescriber, particularly in our very rural frontier areas. Sometimes it's the NP is the only one available to admit. They can't admit. It is against right now some of the administrative code. So they do so under the co-signature of the physician. We also, in Medicare, also at this point in time, allows only physicians to admit, but a physician needs to be brought. So what we want to do is say, that we want to be included in that whole non-discrimination language. It will not clear the way for the advanced practice registered nurse to admit. It does remove one barrier, but it is always up to the hospital medical staff or the credentialing group to say who can be an admitter or a provider of care within their system. There's also another piece that as these nurses, if they get hospital privileging, then there is the requirement or the ask that these APRNPs be specifically named in Wisconsin's Injured Patient and Family Compensation Fund. Now, the Patient Compensation Fund is developed for those individuals, those healthcare providers who get sued for either malpractice or negligence. I mean, we know anybody can sue anybody. And what this does is when the medical, the specific liability insurance that healthcare provider has is exhausted, then the Patient Compensation Fund will come in and continue with the funding of the to make things right, so to speak. So right now we have the CRNA is the only advanced practice nurse group that is named. So it's for example, it's physicians and CRNAs. What we are seeking to do is replace CRNA with the APRNP so that it could be, the nurse midwife who wants to admit, and have that admission be unrestricted, as well as the NP that, who's needing to admit, and our, the other two groups. So, but particularly it'd be the nurse, it impacts the nurse midwife and our nurse practitioners. The last piece to this legislation is the drafter looked at all of our other statutes, state statutes, where had to do with authorizing a physician or a dentist or a podiatrist. And what the current language was that we fixed about 7 years ago with these statutes is we also had advanced practice nurse prescriber included in the statute. So what the drafter did is amend those to just change the word to advanced practice registered nurse prescriber. So what you'll see would be 20 or so other statutes having that sort of amendment to them. And the statutes have to do with infectious disease, having privacy in the nursing home when the NP is providing care. It has to do with I think communicable diseases and an assortment of others that when you look at it and you read it, you would say, oh yeah, that makes sense. Also with the Department of Transportation and indicating that this person, should have further exam or recommend that this person no longer be allowed to drive because of their, could be harmful to themselves or others. So the next steps is We are in the process of finalizing this legislative language, and in terms of process, it takes a legislator to ask the legislative reference bureau, who are the folks that do the drafting, to begin to work with us on the particulars of a bill. So we have been working with the legislative drafter and the legislator who's been kind enough to help us get this developed. Once we are in agreement with the language, we meaning the coalition, we will then begin to seek out sponsors. So we want a sponsor in the Senate, and we would like a sponsor in the Assembly. And the way it kind of works right now is we have a Republican-controlled Assembly, Senate, and the executive branch. So we are, obviously looking for a Republican in both houses. Once we have the sponsor will then circulate the draft to all of the legislators, asking them to sign on as co-sponsors. And the more co-sponsors, the greater the list, usually the better the chance of actually getting the bill out there and getting it talked about, and hopefully getting at least a committee hearing on it. Once it's the co-sponsorship work is completed, it then goes to the House leadership, where it is given a specific bill number. So it could be Senate Bill, 14, or it could be Assembly Bill 90, depending on where it is in terms of the numbering. Once it's assigned a bill number, it will then go to a committee, and the leadership assigns the committee. And in both sides of the houses, we have a health committee, and we think that might be where it will land. And then it's up to the chairperson to decide if they want to have a hearing on it or not. So always lots of politics throughout this process. And while that bill is circulating, WNA and our coalition members will be reaching out to our members and to anyone that's interested in contacting their legislator, asking them to please sign on as a co-sponsor. Hearing from a constituent carries a lot of weight and influence in terms of the actions that a legislator may or may not take. So please remember that. And having it come from a nurse or a nursing student has even greater weight, because it's showing that this is something important to patient care, and it's also something of support to nurses themselves. So we are going to continue to work with the key stakeholders to get this to happen, and ask that you stay tuned by coming to WNA's website, or for those of you that have access to Pulse, our social networking site, our nursing community, we will let you know when it's time for the next step. I hope that this information was useful, and that if you have any questions or would like more information, feel free to just contact the Wisconsin Nurses Association office at info@wisconsonnurses.org.